We can start recording also. I'm gonna start sharing the screen. We're all good. All right. So basically we talked about these 3 layers of the flat muscles. So what's up with the vertical muscles that we talked about? So the vertical muscles, the major vertical muscle that you can find is located, as I said, around the midline, and you have pair of them, so one on each side. These vertical muscles are called as rectus abdominis muscle. That's the major one. It means straight muscle of the abdomen, as the name tells you. Or in the other name, this is the muscle of the six-pack. Okay, so basically the rectus abdominis muscle, it's originating or arising from the upper surface of the pubic symphysis, and then inserts to the sternum and also to the, let's say, costal cartilages of the ribs as well. All right, so the major point is that the origination is from down here. So if you want to work on your abdominal muscles, especially the rectus abdominis, in order to, let's say, have your six packs on, so what we do, we usually do crunches, we do sit-ups. So when you do sit-ups, you're actually, so I can turn on the video and show you. Start video. Let me cancel this. Okay. So basically, when you do sit-ups, you're taking your body, your trunk, close toward your, actually, the origination of the muscle attachment, right? So then when you do sit-ups, you're actually using, all right, your other abdominal muscles, but mainly the rectus abdominis muscle as one of the major ones. And there will be other muscles also associated with it, but the rectus abdominis is the major muscle which is responsible for doing, for example, especially like crunches when you're doing it. So you're putting the most amount of pressure and force on this muscle. Okay, so that's the major thing that I want you to focus on about it. Okay, then. So then that's pretty much about the basics of the rectus abdominis. Few other things that I would like to tell you about it is, first of all, the shape of the rectus abdominis muscle is not the same. Let's say if you compare the inferior part of the muscle and the superior part. What do I mean by that? On the more lower portions of the muscles, the thickness of the muscle is more, so the muscle is thicker, and it's also a bit narrower. But if you're running up closer to its upper attachment, the muscle is wider, but it's like it doesn't have that much of thickness as we had down there. All right, so is, let's say, wide and thin, let's say, on the upper part of the muscle. On the lower part, it's narrow and thick. Okay, so it's more fleshy down here compared to up there. And why do we see it like as packs? I mean, that's a common thing that we say, okay, that person or that athlete has got six packs. So it's because that as you're looking at the muscle, it's kind of divided into parts, and there are areas that you've got some specific fibers called as tendinous intersections. So these tendinous intersections are intersecting the muscle fibers, so it makes it look like different packs. All right, so I mean, here there is no tendinous intersection, it's just the level of the cut which you see over here on this picture. Okay, so that's quite pretty much about the rectus abdominis muscle. The other vertical muscles that you have, at this know it theoretically, anterior to the lower portion of the rectus abdominis, there are like two pyramidal shaped muscles on each side, which are called as pyramidalis. In the book itself, it says like even 20% of the people, they don't even have it. Okay, so you can ask your teacher. If you can show it, good. If not, not a big deal. So major thing is the rectus abdominis muscle over here. So that's pretty much about the major things and about the muscles that you need to know. So now I told you that these flat muscles, which we talked about them, for example, external and internal oblique muscles, these guys are going to be continued together, right? They're going to be continued, or they're going to be replaced by their aponeurosis. Is it true? So what's going to happen to that aponeurosis? So as you see, the aponeurosis is actually running toward the midline, okay? And what you're going to have over here is the rectus abdominis muscle around these regions. And something happened that you're not really able to see the rectus abdominis muscle. So what's going to happen here is that, first of all, these aponeuroses of the muscles, external oblique, internal oblique, and transversus abdominis, these guys are going to be actually make a sandwich out of the rectus abdominis muscle. So these aponeurotic fibers, they are actually wrapping, or they're running around, means anterior and posterior to the rectus abdominis, and they make a sheath around the muscle, around the rectus abdominis muscle, which is called as rectus sheath. Okay, so basically the rectus sheath is a tendinous sheath, or is an aponeurotic sheath formed by the aponeuroses of the flat muscles of the abdominal wall around the rectus abdominis muscle. And then these fibers, which are forming the rectus sheath, so these aponeuroses, which are forming the rectus sheath in the midline, they actually cross over each other, so they decussate and they form a white line or white colored raphe, which is running down, called as linea alba. Alba in Latin means white, so white line. Okay, so even again on those athletes that you're able to see their six pack, definitely you can see a kind of deepening line between the rectus abdominis muscles running down all the way. So that's going to be what? That's going to be the linea alba. This is where the fibers of the rectus sheath, which is formed by the aponeuroses, are meeting with each other on each side. Okay, then. So what we're going to see over here is that we have made a cut, let's say up here, means above the umbilicus, over the rectus abdominis muscle, and we are just looking at one side. Okay, so here's a left side, for example, that we are looking at it. So you have the layers of the abdominal wall we talked about: skin, fat, or the subcutaneous tissue. Then you have external, internal, and external, internal oblique muscles, and then over here is a transversus abdominis. Then you have their investing layers covering them, and they form the aponeuroses. Okay, external oblique aponeuroses, internal oblique aponeuroses, and transversus abdominis aponeuroses. Deeper to the transversus abdominis, over here you have the transversalis fascia. Then you've got the extraperitoneal fat, the yellow line over there, and then you have the parietal peritoneum. So that's how, again, you will make it there into the abdominal cavity. So now, what we're gonna see is that these aponeuroses, they are actually gonna be forming an aponeurotic sheath around the rectus abdominis muscle, which we call it as rectus sheath, right? So then you can see that over here, the aponeurosis of the external oblique is running anterior to the rectus abdominis muscle. So basically it forms the anterior wall of the rectus sheath. That's how we call it. Then over here you have the internal oblique aponeurosis. Well, the thing with this guy is that it divides into an anterior and posterior lamina. Anterior lamina runs together with the aponeurosis of the external oblique, so they form the anterior wall of the rectus sheath. The posterior lamina runs with the aponeurosis of the transversus abdominis, and they form the posterior wall of the rectus sheath. Okay, So what's going to happen in the midline? So let's say here's one rectus abdominis, then the other rectus abdominis muscle will be there if I complete the drawing. So what's really going to happen here is that at the linea alba, which is here in the midline, okay, at the linea alba, we're going to see that the aponeurosis of the internal oblique is going to be, since the fibers of these, let's say, rectus sheath are becussating or crossing over, the aponeurosis of the internal oblique is going to become continuous with the aponeurosis of the external oblique. And aponeurosis of the external oblique of this side is going to be continuous with the aponeurosis of the internal oblique of the opposite side. So basically, in this way, we connect the external oblique muscle of one side with internal oblique muscle of the other side. You know, you get what I mean? So if you think it through, it means that these two oblique muscles, they are actually acting like a digastric muscle, because one muscle is on this side, then through the aponeurosis, you get connected with the other muscle on the other side. Okay, so you can imagine that these muscles, then they are running and they are working actually together. So then, if you see over here, for example, if you're doing, let's say, or if you're doing crunches, for example, and you're doing it in a rotational way. So once I'm rotating my trunk, so what I'm doing, I'm actually moving my, for example, right shoulder toward the left side of my body, right? So in this case, it means that my right external oblique is working, and from the other side, my left internal oblique is working, because their aponeurosis are continuous with each other. So when these two muscles are working together, then I'm actually able to do the crunch coming up and then actually make also a rotational movement. So this is how these oblique muscles are working together. So external with the internal of the opposite side. Again, if I move my right shoulder toward the left, let's say knee, if I'm doing crunches or sit-ups or whatever, like in a rotational way, so my right external oblique is working or it's acting, and also from the other side, the left internal oblique is acting with it together. Okay, because of the continuity of the aponeurosis and all those crossovers which is happening in the let's say in the midline, where the linea alba is actually formed over here in the midline. All right, so that's pretty much about the majority of the rectus sheath and the way which is formed. But the thing is that, again, if you run down below the umbilicus, again, you will have some minor differences. What do I mean by that? It means that something will happen. So if you're actually dividing the way or the distance between the umbilicus and the pubic symphysis, so if you run 1/3 of the way, so the lower 2/3, you will have some differences actually to be formed. How is that happening? Is that we are looking at the same side, but just on the more inferior level. So you can actually find the rectus abdominis, good, external, internal oblique, transversus abdominis, all fine. But the difference here is that the aponeurosis of the external, internal oblique and transversus abdominis, they are actually running anterior to the rectus abdominis muscle. So here's the aponeurosis. They want to form the rectus sheath, but the rectus sheath itself is running anterior to the rectus abdominis muscle. So what's just going to be left posterior to the rectus abdominis is going to be the transversalis fascia, which was actually the endo-abdominal fascia. Up there, how was it? So we had external oblique, internal dividing into 2 layers, and then transversus abdominis aponeurosis. So posterior and anterior wall. But over here, like all those aponeuroses, instead of being divided and running posterior and anterior to the muscle, they are all just run anteriorly. Okay, so again, what's just going to be left posterior to the rectus abdominis is the transversalis fascia, or as I said, the endo-abdominal fascia. So how would you define the border? Because over here, if you look, the posterior wall of the rectus sheath, so definitely is thicker, but down here, the posterior wall of it is thinner because there is just one fascia located back there. So actually, if you run down here, so here on the right side, nothing is dissected, okay? So you can see, let's say, the internal oblique muscle, external oblique muscle is dissected, but here you have the aponeurosis intact, so you cannot see the rectus abdominis on this side because you have the anterior wall of the rectus sheath intact. In the midline, you have the linea alba, and that's where you have the umbilicus. On the other side, actually you can see that the rectus abdominis muscle is cut. So it means that the anterior wall of the rectus sheath is opened up, the rectus abdominis muscle is cut and it's taken out. So over here, you're looking at the posterior wall of the rectus sheath all the way, okay? So then you can see all the way, the posterior wall is white and thick until down here, you can see a sharp border, and then you will see a change in the color. The change in the color is because that the posterior wall becomes thinner, okay? So back here, you have the aponeurosis of the transversus and internal oblique until here. At this point, all those aponeuroses start to run anterior to the muscle. So what's going to be left at the back is the, well, transversalis fascia. So you can see that you can find a kind of, let's say, arch-shaped line. So above it is the thick portion, below it is a thin portion, which is the only fascia located there is a transversalis fascia. So this sharp border is called as arcuate line. So arcuate line is a question that they usually ask you. It shows you the transition and the change that you will have in the way that you form the walls of the rectus sheath, okay? So above the arcuate line was what we saw up here. Below the arcuate line is what we see down here, okay? So that's quite important. You need to know about it. On this other picture over here on the right side, you're looking at the, let's say, sagittal cut. So you have got the skin and everything. Again, the green guy, so here's the rectus abdominis. The green guy is external oblique aponeurosis, anterior lamina of the internal oblique, posterior lamina of internal oblique, transversus abdominis, and the gray guy over here is the transversalis fascia or endo-abdominal. Good. Over here, you can find the peritoneum, an extra peritoneal fat between them. So you're going down until you see that these two layers, they just run anteriorly. Okay, so everything is going to be, all the aponeuroses are going to be located anterior to the lower portion of the rectus abdominis, except the transversalis fascia, which is down there, keep running inferiorly. Okay, what else do we find in the rectus sheath actually? So what else you find in the rectus sheath other than the rectus abdominis muscle? So since the muscle is removed, you can find this artery running up posterior to the muscle. This is called as inferior epigastric artery, and the vein is next to it. From the superior side, as a terminal branch of internal thoracic, you have the superior epigastric artery. So these guys anastomize with each other in the rectus sheath, posterior to the muscle. You had those thoracoabdominal nerves, which were the 7th to 11th intercostal nerves. You remember I told you that those are the atypical nerves and so on. Those thoracoabdominal nerves, their terminal parts will reach into the rectus sheath in order to supply, first of all, the rectus abdominis muscle, and from the other side, they would give their anterior cutaneous branches around the midline. And also you have the nerve of, let's say, T12, the subcostal nerve, and also branches from L1 as well. So you've got the muscle, rectus abdominis muscle, blood vessels, inferior and superior epigastric. You have the nerves, and of course, you also have the lymphatics as well. So these are the structures that you're able to find in the rectus sheath. What else we have? So we've got the linea alba, as I said, which is formed by the decussation of the fibers forming the rectus sheath. So forms a white line running down all the way. So linea alba, as I just said, is where you have the decussation of the, or crossing over of the fibers of the aponeurosis to form it. That's it. Then we are talking about the umbilicus. So basically the umbilicus is, well, defined as umbilical ring in the linea alba. So there is a ring. So basically there is a ring shape defect in the linea alba. Why? Because this was the way that makes the connection between the embryo and the mother. So you have the umbilical cord passing through the umbilicus containing the umbilical vessels. And from one side, so it's connected to the baby. From the other side, it's connected to the placenta of the mother. So then at this point where you have the umbilical ring, this is where the whole layers of the abdominal wall, they are actually fused with each other, first of all. And after the baby is born, so once you're having the umbilical ring to be closed off, so since the whole umbilical cord and everything is out, then umbilicus is going to be actually depressed, or it's going to look depressed like what we see over here. So you can see that the skin around the umbilical ring or around the umbilicus is actually protruded, because after the birth, once the baby is starting to get more and more weight, so let's say within 7 to 14 days, more amount of fat is going to be accumulating around the umbilical ring. That's why the skin around it is going to be protruded, and the umbilicus itself is going to be depressed in the center of it. All right. So that's pretty much, and there is no more to tell you. So it's mainly, as I said, theoretical. All right. So this was a major part about the muscles and blood vessels. I mean, the muscles and the major things about the abdominal wall. The easy part comes now. So the nerves of the anterolateral abdominal wall. So you have thoraco-abdominal nerves, which were T7 to T11. You have the subcostal nerve, all right? And then you're gonna have also two branches from the lumbar plexus, iliohypogastric nerve and ilioinguinal nerve. So the areas that these nerves would supply the skin, first of all, learn it in this way. Area around the umbilicus is supplied by the T10 segment of the spinal cord. So everything above the umbilicus is going to be, let's say, T9 downward, so T9, 8, 7, and so on. And below the umbilicus, you're going to have the T11, 12, and also L1 region. So the L1 region is basically done by iliohypogastric and ilioinguinal nerves. All right, so that's the easy way. The way or the pattern that the nerves are giving the branches, so we know that around the mid-axillary line, you would have the lateral cutaneous branches to arise, right? And then the major nerve keeps running to supply the muscles of the abdominal wall. So the terminal point of the nerves enter the rectus sheath, and around the midline, they're going to give out these anterior cutaneous branches to supply the skin around the midline of the body, all right, on each side. So the nerves were easy, like not much to talk about it, as you see. Now, let's make it down to the major arteries that we can have. Let me just see if I missed anything else. No, everything is there. So the nerves were just, that's it. About the arteries. So up there, you have the internal thoracic artery running down from the subclavian. I already told you in the thorax that it divides into musculophrenic and superior epigastric branches as terminal branches. Later on, we will learn that the superior epigastric artery passes through the diaphragm, enters the abdomen. So basically, you can see that the superior epigastric artery runs posterior to the rectus abdominis in the rectus sheath. From the other side, here's the inguinal ligament. Above the inguinal ligament, you have the external iliac artery. Below the inguinal ligament, you have the femoral artery. All right. So what we're going to have here is that from the external iliac artery, so right at the terminal part, you have this branch which runs medially and superiorly toward the anterior abdominal wall, enters the rectus sheath. This is going to be the posterior, it's going to be the inferior epigastric artery, which runs posterior to the rectus abdominis muscle. So inferior epigastric supplies the muscle basically, and also anastomizes with the superior epigastric. From the other side, we can see that external iliac artery gives you another branch. This branch runs along the inguinal ligament and iliac crest, and this is called as deep circumflex iliac artery. So nicely visible on the cadaver. So you can find both inferior epigastric and deep circumflex iliac arteries. You can find both of them so easily. So you just have to look at the terminal part of the external iliac artery, and you will just follow the way that the branches are running, and that's it. You're going to be good. So down here, once you have the femoral artery gives you one branch, runs superiorly and superficially toward the more superficial structures of the anterolateral abdominal wall. So you have this artery called as superficial epigastric artery because it's superficially located. The other branch of the femoral artery, so these two are mainly theory, right? The other branch is going to be again running along with the iliac crest, and that's going to be called as superficial circumflex iliac. So deep circumflex iliac is from external iliac. Superficial circumflex iliac is from femoral artery. What else do we have? You have branches from 10th and 11th posterior intercostal arteries, and you also have the subcostal artery as well, which are coming from the abdominal aorta. So these are also the other arteries that are involved in supplying the anterolateral abdominal wall. So you see, everything is simple and it's not a big deal at all. So the whole thing about the arteries are explained over here. Good. In the case of the venous drainage of the abdominal wall, so we have a subcutaneous venous plexus called, subcutaneous venous plexus. Superiorly, this venous plexus drains either toward the internal thoracic vein or axillary vein via the lateral thoracic vein. More inferior part of it drains toward the superficial epigastric vein, and following that, it will drain into the femoral vein. Or maybe some deeper veins would run toward the external iliac vein, okay? So the major veins that we have over there, so in the deep regions, for example, we have the superior epigastric artery. So you have the vein of the same name running together with it toward the internal thoracic. Inferior epigastric is running toward the external iliac vein. You know that the superficial runs toward the femoral vein, and so on. So everything else is the same, okay? So the venous drainage is quite straightforward. And there is a vein which is actually connecting the superficial epigastric vein to the lateral thoracic vein. So you see it's running all the way up. The vein is called as thoracoepigastric vein. Maybe not everyone have it, but still it can be there. At least know it theoretically for final, not for the ID exam. All right. In the case of the lymphatic drainage, super easy. You draw the transumbilical plane. Everything above it either mainly drains into the axillary lymph nodes, and some other lymph which are located up there are going to be running toward the parasternal lymph nodes or anterior diaphragmatic lymph nodes. Okay, so easy. Below the transumbilical line, the lymph is running mainly, since this is superficial, is running toward the superficial inguinal lymph nodes. From there, it runs toward the deep inguinal lymph nodes and then external iliac lymph nodes. The deeper portions of the, let's say, anterior abdominal wall, its lymphs are going to be running toward the external iliac lymph nodes or common iliac lymph nodes. Exactly same as the venous drainage and the way that the veins are running. So the lymphatic drainage is just easy. Again, you're not going to need it for the ID exam. It's just for the final. But keep it simple in your head, even for the final. Transumbilical plane, above it, the major one is axillary and parasternal. Inferior to it is the superficial inguinal lymph nodes. These are the major ones to know. All right, so that's pretty much about the venous drainage, lymphatic drainage, blood supply, and nerve supply of the anterolateral abdominal wall. Okay, then. Let's give it like 3-4 minutes of break. So if you need to grab something to drink or something, and then we're gonna start the last part of the class in a